Thank you. Thanks very much for inviting us to present our data. It's a pleasure to be here. So the first of my 3 abstracts I'll be presenting is to look at whether older adults with overactive bladder demonstrate impaired executive function compared to their peers who do not have that diagnosis. This project was funded by the Canadian Geriatric Society and Pfizer, to whom we're grateful. My disclosure is I've accepted speaker fees and research funding from Pfizer and Astellas. So we all know that the maintenance of continence is not an automatic process. It's one that we learn early in life. And maintaining an awareness of our bladder volume and our need to void is reliant on careful coordination of sensory input from the lower urinary tract and the activity of multiple areas of the brain, including quite a bit of the prefrontal and frontal cortices. We also know that the prevalence of incontinence and lower urinary tract symptoms increases significantly with age, and it's been suggested by several authors that OAB may well be as much a disease of the brain as it is of the bladder in older people. So we hypothesized that we will be able to demonstrate impaired executive function in people with OAB compared to a similar cohort without OAB using a simple bedside test. So this is an exploratory cross-sectional study in adults aged 65 and over, comparing the performance on 2 cognitive tests, the trail-making B test, which is where our participants were asked to link 25 circles alternating from number to letter to number, increasing from the first, which was A, up to the last with 25, up to 13, and a test of simple reaction time, which is a computer-based test where our participants pressed the spacebar as quickly as possible when an indicator changed from red to green. We had 2 groups, an OAB group, who we defined as having urgency, as per the ICS definition, 8 or more voids per 24 hours, and a weekly urgency incontinence or more. Our control group were defined as having a bladder control self-assessment questionnaire score of 4 or less. These were recruited from the community using advertisements in local newspapers. Our exclusion criteria were anyone with either diagnosed or subjective cognitive impairment, sensory impairment that would interfere with their data collection, and anyone who was being treated for their OAB with pharmacological measures. So the trail-making B test is a validated test of executive function. We used an online simple reaction time test and averaged 5 attempts. We also collected demographics, a Charlson comorbidity index, a list of their medications, and we calculated an anticholinergic burden score. We compared these with independent sample t-tests or Mann-Whitney U-tests, depending on the distribution of the data. So these are our results. We recruited 56 patients, 35 of whom we defined as having OAB, 21 formed our control group. They were very similar in age. They were slightly more women in the OAB group than in the control group. That was very close to significance, but wasn't quite. Charlson comorbidity indices were not statistically different, neither the number of medications taken nor their anticholinergic burden. So they were a fairly well-paired group. The cognitive testing results are shown here. So of interest, our trail-making B test time was 103 seconds in our OAB group compared to 77 seconds in our control group, which is significant. There was no difference in the number of errors made by the group between the groups and no difference in their simple reaction time. It's worth noting that all of our participants voided immediately before performing these tests, and you'll see why when I do my next abstract in about 2 minutes. So our OAB group took significantly longer to complete the trail-making B test than did our control group. This suggests that our OAB group had worse executive function than the control group, despite there being no significant differences in age, comorbidities, medication use, or anticholinergic burden, and none of our participants felt they had any cognitive impairment. Conclusions that we can draw from this from a clinical perspective are that if we identify someone in clinic with executive dysfunction, we should ask them about their bladder, and there is work from a research perspective as whether or not they would benefit from prophylactic bladder training. There's also an unexplained association between falls and low urinary tract symptoms in older people. Maintenance of balance and gait is also an executive function, and this may well form part of that explanation. Thank you very much for your attention.
The floor is now open for questions.
I'm just glad Adrian's on, he's still sat there.
I was just wondering, did you have Did you look at sort of stress urinary incontinence as well, or the mixed urinary incontinence among these patients?
No, this group were purely OAB. I know your co-chair has presented previously that mixed and stress incontinence are also associated with executive dysfunction. But no, we had a pure urgency incontinence group.
Hi, Banty Fader from Southampton, UK. Enjoyed that. Question about, you didn't include people with cognitive impairment, but you didn't test for cognitive impairment. And in terms of things like mini-mental state or any of the other established tests. So could you be confident that you actually didn't have there were any differences there?
We can't be confident, but that's kind of our conclusion, isn't it? That our OAB group had undetected and asymptomatic cognitive impairment. So yes, we could have done more in-depth cognitive testing, we could have done a full MOCA. We considered excluding those who had, doing cognitive testing at the beginning and then excluding them, but that would then muddy the water in terms of what we're actually looking for. We chose a specific cognitive test and used that as an outcome measure, so we couldn't also use it as an inclusion criteria.
Yeah, I suppose I thought it would be useful to see if they went hand in hand, and therefore, and because obviously testing for cognitive impairment is more common, I guess.
Yes.
And perhaps easier to do and more established than doing sort of sequences of rings and stuff like that.
But also less sensitive.
Yeah, indeed. Okay, thank you.
Hello, hi, Jo Booth from the UK. Just really sort of following on a bit from Mandy, were you aware that all of these participants had manual dexterity, i.e. could they work the computer, and were they physically competent to do these tests?
They were. We excluded people who were physically incapable of doing the test. The reaction time was literally pressing a space bar, so required very little movement. Trail making B, as you know, requires the ability to hold and use a pen. But no, we didn't specifically ask them to do it first. We gave them all a trial run, and all of our participants were physically able to do the testing.
And the comorbidities were?
Yeah.
Yeah.
Okay, we'll go on
I'll
to
move
the
on.
next.
I'll stay where I am.
Okay, so your next presentation, Dr. Gibson, is the strong desire to avoid a source of diverted attention in older adults without lower urinary tract symptoms.
And so my disclosures haven't changed in the last 5 minutes. Once again, urinary continence and the maintenance of continence is an active cognitive process and a learned skill. There is a strong yet unexplained association between falls and lower urinary tract symptoms, including urgency incontinence, and nocturia in older people. There's also evidence from some groups and data that we presented here last year that the sensation of a strong desire to void, so physiological urge rather than pathological urgency, has effects on cognitive function in young adults. Diverted attention is the concept that if you're trying to do two tasks at the same time, you don't do either of them as well. And this is why in the vast majority of countries it's illegal to talk on the phone while you're driving, because it distracts you. It's well known that diverted attention leads to gait changes in older adults. It's also known that older adults who stop walking while you talk to them are at significantly increased risk of falls. So we hypothesized on this study that the sensation of a strong desire to void will act as a source of diverted attention in older adults, leading to a change in performance on cognitive tests. So we recruited volunteers without low urinary tract symptoms by advertising in local newspapers and the local press. They were aged 65 and over, had a BSAC score of 4 or less, they were cognitively intact with a Montreal Cognitive Assessment score of 26 or more, and they had no significant sensory impairment that would interfere with cognitive testing, so colour blindness or deafness. Again, they completed 2 cognitive tests, the Trail Making B test and a computer-based test of simple reaction time. And this group completed these tests under 3 conditions: when they had an empty bladder, having just voided and were not being distracted; when we were distracting them by asking them to perform something called the N-back test, where the examiner reads out a list of letters, and when the letter read out is the same as 2 previously in the sequence, they rang a bell with their non-dominant hand. This is a validated source of diverted attention. It's extremely distracting and very difficult to do. And we induced a strong desire to void. We did this by giving them non-alcoholic, non-caffeinated beverages to drink freely until they couldn't defer voiding anymore. We gave them the example as if they were in a movie theatre enjoying a film. the point at which they would have to get up and leave rather than stay and watch the end of the film. We didn't do a visual analog scale or use any measures of urgency because we felt that this would add to the time taken for the cognitive testing. And we'd predefined that if we did a VAS, we'd want them to be scoring a 10 anyway, so we didn't formally measure that. This was a within subjects repeated measures design. We were planning on doing an ANOVA, but unfortunately the gods of statistics were not kind, so we had to do a Friedman test because the data weren't appropriately distributed. So we recruited 21 people. Their mean age was 72.4 years, ranging from 66 to 86. 8 were male, 13 female. And these are our cognitive testing results. So the trail-making B time was not affected by the strong desire to avoid, going from 77 seconds to 81, but was significantly increased by distraction. But their simple reaction time increased from 451 milliseconds when undistracted to 515 milliseconds when experiencing a strong desire to avoid, and 885 milliseconds when distracted, both of those significant at less than 0.001. These are the results in graphical form. So on the left of your screen are the results for undistracted to strong desire to avoid, on the right from distracted to distracted. So these are the individual data points. So in this small study, the strong desire to avoid induced a smaller but similar change in reaction time when compared to a distracting task, and it wasn't seen with the trail-making B test. This increase in reaction time, to put in context, is more than you get when you are too drunk to drive. And we conclude from this that the strong desire to avoid may be acting as a source of diverted attention in older people who do not have lower urinary tract symptoms. Thank you very much.
Thank you. The floor is now open for question.
Mandy Fader again. On a personal note, I can really go for the strong desire to avoid being a big distraction. So I imagine that I could really see how that would be important, but I'm wondering what use is it? So in the sense of what can you do with that, and how you clinically?
So I think there's two things to consider. Firstly, from a sort of public safety perspective, we don't allow people to drive when drunk. We don't allow people to drive when talking on their phone. Should we also let it be known that you really shouldn't be driving when you really, really need to pee? There is this association between falls and low urinary tract symptoms in older people, and I'm about to present some data in people with LUTs. If you consider the suppression of urge and urgency as an active cognitive process which acts as a distractor, that would fit with the idea that urgency and urge are acting as a source of diverted attention, and that is why older people with LUTs are more likely to fall. We know from other work that dual task training, so physiotherapy that involves both balance and mobility as well as cognitive tasks simultaneously, reduce the impact of distraction on the gait in older people. So this piece fits in with that larger idea that urgency is acting as a source of diverted attention. What we've demonstrated here is that even in people without LUTs, it's also acting as a source of diverted attention.
Okay, thank you.
Thank you. Another question from the audience?
It's not a question, it's an anecdote.
Oh, cool.
In the paper about 6 or 7 years ago, a London bus driver drove her bus the wrong way up Piccadilly and was filmed doing this in the centre of London because she needed to pee. That was the paper.
I think we've all been in a situation where you're trying to finish a paper or do your talk for ICS and you really need to pee and you just want to get the slides finished. You just can't concentrate. I think these data confirm what everyday experience tells us.